So, Henoch-Schönlein purpura. What causes it, how does it present, and what is its course? In clinical practice, the terms Henoch-Schönlein purpura and IgA vasculitis are commonly used interchangeably. IgA vasculitis was first recognised by Dr. Heberdin in the 1800s as a condition that caused pain and swelling in various parts of the body as well as hematuria. It was a few decades later that Schönlein and Henoch made the connection between an upper respiratory tract infection and later having this presentation. They described a palpable, non-blanching purpuric rash which appeared almost meningococcal-like. It was thought previously that this condition was self-limiting, with little to no adverse short or long-term effects. However, they highlighted that serious kidney involvement may be a consequence. Nearly 200 years after HSP's recognition, there is still much deliberation over its underlying cause. What is the mechanism of action behind HSP? There are two leading theories. The first involves a defective IgA molecule, whilst the other involves an autoantibody against IgA on endothelial cells. By far, it seems that the defective IgA structure is most widely recognised. So, what is this all about?
The structure of the antibody, as I'm sure you will all know, heavy chains and identical light chains. The heavy chains and light chains are connected by disulfide bonds. They have both a constant Fc region and a Fab component. I'm sure this is bringing back some fond memories of principles. But did you know the popular dating app Hinge, who some of you may have more recent memories of, is not only successful in bringing people together, but crucial in joining the Fab and Fc region to form the immunoglobulin. The unique structure of the hinge segment is crucial in providing segmental flexibility, which is essential for normal functioning of antibodies. Usually, on a normal functioning immunoglobulin, glycosylation occurs at the hinge region. This involves the attachment of carbohydrates to the backbone of a protein through an enzymatic reaction. In HSP, it is believed the process is abnormal due to a defective hinge region. A substance called GalNAc on the immunoglobulin becomes exposed. This causes the structure to be recognised as non-self. Antibodies are formed against this IgA and form immune complexes. Both the abnormal IgA and immune complexes circulate at the same time. These cannot be cleared by the body and instead deposit in small blood vessels. Along with the IgA deposition, we see lots of inflammatory cells and the complement system also. IgA is normally present in the mucosal secretions and acts as a first line of defence against pathogens. It is present in the oral cavity and lining throughout the gut. This inflammatory process causes vasodilation and the characteristic skin rash. The leaking of these small blood vessels also causes a similar appearance in the lining of the gut if viewed on endoscopy. A clear link exists between strep A infection and IgA vasculitis due to the molecular mimicry and cross-reactivity.
So how does it present? IgA vasculitis is mainly a disease of childhood and the peak incidence is between 4 and 7 years old. 95% of patients have skin involvement, characteristically a symmetrically distributed rash. The rash begins on the ankles and feet and extends upwards. Typically the arms and legs are affected. There may also be localised skin edema and rarely the skin can become necrotic. The other 5% have abdominal pain and the rash occurs secondly. The GI involvement can range from mild abdominal pain to life-threatening bleeding or intussusception. Joint pain can also occur and in males inflammation of the test. 40 to 50% have some renal involvement and very rarely there may be neurological or lung involvement. The adult population are more likely to suffer from these rarer presentations. The natural history of the disease is positive and the majority of children get better with around 70% making a full recovery at 70 days. However, it usually only lasts on average a month. 4 in 10 will have some degree of inflammation of the kidneys and of them 20% will go on to get irreversible CKD needing dialysis or a transplant in the future. Around 25% will have relapse or persisting rash and this may require special. To reiterate, many kids will make
A fab recovery.